Good afternoon. Welcome to the panel Mpox Community Solidarity, organized by ACU Innovation and Consulting and the Global Advisory Board for Sexual Health and Wellbeing, the GAB. I'm Antón Castellanos Usigli, founder and CEO of ACU Innovation and Consulting and a member of the GAB. Today, we will have a discussion on the landscape of the international Mpox outbreak in the Americas and in Europe, and we have a fantastic set of speakers with us. I'll begin by introducing each one of them. We have Dr. Antonio Gerbase, a consultant from WHO Europe in Switzerland. Carlos Restrepo, president and founder of Impulse Group Sao Paulo in Brazil. Dr. Félix Pérez, clinical research coordinator at Checkpoint Barcelona in Spain. Gustavo Morales, director of access to care at the Latino Commission on AIDS in the US. Dr. Jorge Saavedra, executive director of the AHF Global Public Health Institute in the US. Dr. Ken Mayer, medical research director from the Fenway Institute in the US. Dr. Ricardo Baruch, community advisory board coordinator at Clínica Viva in Mexico. Dr. Will Notland, from the co-founder of the Love Tank CIC in the UK. And Lauren Campbell, who is a consultant working with me at ACU Innovation and Consulting, will be facilitating the question and answer section at the end of the panel. Lauren, where should participants watching the panel put their questions as we move along in the discussion?
Yeah, of course. Thank you so much for the introduction, Anton. If you have any questions that come to mind during the panel discussion, please submit them as comments to the YouTube live stream. We'll be collecting your questions throughout the entire session, so please submit them as you think of them, and our panelists will try to answer as many as possible after the initial discussion.
Thank you so much, Lauren. And finally, I also want to acknowledge Gerardo Arriaga, who is supporting behind the scenes to ensure that the panel goes smoothly. Thank you so much, Gerardo. And before we start the discussion with the panelists, I'd like to introduce the audience to a document, the Mpox Community Solidarity Guide, a guide to strengthen Mpox education, health services, and advocacy for gay and bisexual men. So this guide, which is available in English and in Spanish, is a technical guidance document for organizations. It was produced by the Global Advisory Board for Sexual Health and Wellbeing and ACU Innovation and Consulting, and it was a project funded by RECIT. We created the guide because during the summer and fall of last year, we were seeing that some governments, especially in Latin America, were failing to say things as they are in regards to the fact that the Mpox outbreak has mostly been spreading through sexual relationships among men. Some governments were failing to provide adequate prevention information to gay and bisexual men, and overall failing to provide an adequate public health response to protect the health and well-being of this population. So this guide was based on a review of educational materials about Mpox in both English and in Spanish, and through interviews with experts and activists, some of which are present today. So before we get started, I'd just like to show the audience how the document looks like, and I'll proceed to share my screen. Let's see. I'm showing my screen, right? Okay, so this is what the document looks like. You can find it online in the website of ACU Innovation and Consulting. Under the projects menu, technical guidance document, you'll find both the English and the Spanish versions. And so the document starts by putting on the table the landscape of the international outbreak with data as of December 2022. We explain a little bit about the methodology, which is what I just described, the review of educational materials that we did, alongside with the interviews with experts and activists. Then a note about the people who were involved, who contributed. Just want to take a second to acknowledge Jose Antonio Lozano from RECIT, who has provided a lot of support towards the project. And then some of the interviewed experts are here present today, such as Dr. Jorge Saavedra, Ken Mayer, Ricardo Baruch, Dr. Ruben Mayorga from the Pan American Health Organization also contributed, Alain Pinzon from Mexico Vive Libre, a community-based organization in Mexico City, Dr. Julia Fleming from the Fenway Institute, and Roy Wadia from the WHO European Office as well. Thank you all so much for contributing. And so the document has three parts. The first one talks about how to strengthen education and information for gay and bisexual men around Mpox. And the first theme is around the importance of communication that is relevant to gay and bisexual men. So we talk here about the fact that gay and bi men have been the most affected population during this outbreak, and the transmission has been happening primarily through sexual relationships, which is a fact that not a lot of governments and media were acknowledging back in the fall and in the summer of last year. Throughout the document, we also include some lessons from the HIV and AIDS pandemic that apply to the international Mpox outbreak. And you can see here one on the screen, which speaks about the importance of having educational materials created by the community for the community. Throughout the document, you'll be able to see as well quotes from the experts and activists who contributed with their knowledge to the creation of the document. Then another theme that's related to communication is the fact that many governments and organizations, unfortunately, were not showing pictures of genital and anal lesions as they are. And so these types of photos have been presented mostly in scientific conferences, but not as part of educational materials for the community to be more informed about how the lesions look like. And so we talk a little bit about that. We present, for instance, images of an infographic developed by the Mexican government, which doesn't do a good job at all in conveying the sense of what the lesions look like. As you can see here on the screen, they just showcase cartoonish Mpox lesions in the face of a girl and woman, which is really not applicable to what's been happening with the outbreak. Then we include examples of materials developed by the organization Vive Libre in Mexico, which speak clearly to the fact that the majority of the lesions have been happening in genital, anal areas. And then we delve into prevention through solidarity. So all about risk reduction, sexual partners, communication, and body exploration. We talk about the importance of community solidarity and communication with sexual partners, condoms as risk reduction tools for the prevention of internal lesions, and then a set of considerations for people with Mpox, something about the recovery period, the importance of not having sex during recovery, pain associated with Mpox lesions. And so we include here an example of a community-led research effort in New York, Respond MI, that was led by Keletso Makofane and others, that developed lists of over-the-counter pain medications that could relieve pain as an example of a good practice by a community organization. The importance of peer-to-peer support, stigma associated with Mpox, sex after recovery, and then the piece around how community-based organizations can link people to sexual health services and to health services overall, having an updated list of health organizations that can diagnose Mpox and provide medical attention, promoting vaccination in places where it is available. Unfortunately, in Mexico and in some other places, vaccine is still not available. Then we have a summary of do's for Mpox educational materials, tips for greater educational impact, and then some more examples of quality educational resources developed by the community for the community. We present here resources from the UK, Mexico, US, etc. Then the second part of the document has to do with strengthening health services. We talk about the importance of medical providers with LGBTQ competency, integrating Mpox in prevention and care, Mpox prevention and care into sexual health services. And then some notes around the importance of sexual history taking for the provision of education, for prevention, and for treatment. In this slide, we include some variables that are key for sexual history taking with gay and bisexual men who express medical concerns about Mpox. And then the third section of the document has to do with strengthening advocacy. So we include here the importance of uniting the LGBTQ movement to demand access to the vaccine, the need for governments to scale up testing, the importance of getting businesses involved from saunas, clubs, bars, all the way to dating apps. For instance, Grindr has been doing a partnership with the organization Building Healthy Online Communities with local public health departments to send alerts and resources to people. And you can see here two examples, one from the US and one from Spain, as examples of good practices. And then we include the declaration of the Gay Latino Network. The Gay Latino Network is the largest Latin American network of gay leaders. And they met in August of last year and released a declaration on Mpox, in which they call governments in Latin America to do better when it comes to the response to this outbreak. And then an example as well of a community-based advocacy campaign in Mexico City, Respuesta a la Viruela Símica México, which was demanding access for the vaccine, which unfortunately is still not available in Mexico. And so in a nutshell, this is how the document looks like. I invite you to either download it from the website of ACU Innovation and Consulting or download it directly from the bit.ly that you will see on the screen. And so in our discussion today, we'll basically touch some of the themes that the document includes. And so I'd like to start with the topic on stigma. So we'll have a series of questions. And for each question, I just ask the panelists if you can keep your responses brief, up to 3 minutes. We have around 60 minutes for this discussion, and then we'll go to the Q&A section that Lauren is going to facilitate at the end. And so stigma is one of the topics that the document includes, and we've seen it in different ways throughout the international Mpox outbreak that began last year. So some governments and media haven't said things as they are, that transmission is happening among gay and bisexual men through sexual relationships. So I'd like to ask Jorge, Gustavo, Will, and Carlos, if we go in that same order, what types of stigma have you seen during the outbreak, and where have you seen it the most? And perhaps, Jorge, we can start with you.
Okay, thank you, Antón. And probably I will start with something that is not exactly a response, but it addresses your question. Because I will start by saying that we shouldn't stigmatize stigma. Of course, stigma is a negative connotation, but the stigma argument should not be used as a reason to paralyze our response, or not as a reason to lie or diminish the importance of a disease that has in a specific population. And I will share you a story. At the end of the 90s in Mexico, some gay groups had managed to influence the government to de-stigmatize HIV infection, asking the government not to insist on saying that HIV primarily affected gay and bisexual men. So by then, I was doing an analysis in health economics at the time, and then I was invited to evaluate the use of public health resources for HIV in Mexico and in Latin America. And one of the findings was that in Mexico, the budget for HIV prevention was allocated to prevent HIV in women, in children, in adolescents, in indigenous populations, in migrants, you name it, and absolutely $0 to projects aimed to prevention of HIV in gay and bisexual men. Why? In order not to stigmatize. So gay groups were insisting, don't associate HIV with us, and then the government say, we accept that challenge. So $0 for HIV prevention in gay groups, for not stigmatizing them, and they were using the money to do with many other groups, but except gay men. So at the end of the 90s as well, it was also insisted that in Central America, unlike Mexico, the HIV epidemic was primarily heterosexually transmitted. With a more detailed analysis, we found out that in Central American countries, they simply did not ask about sexual orientation or the route of transmission, the mode of transmission, about sexual practices of people diagnosed with HIV. Why? In order not to stigmatize. And therefore, there was a lie that in Central America, the HIV epidemic was primarily affecting heterosexual population. So these two examples, both from Mexico and Central America, show that the fear or excuse of stigmatization can lead to wrong decision making that in the end will affect the health of those who are intended to be protected from stigma. So, okay, you're trying to protect them from stigma, and then you damage them because the health issues and the stigma fear, they won't do things in order to help them or information to try to make them change whatever is needed to be changed. The same is happening now with Mpox. I think the request not to associate Mpox with gay and bisexual population can have counterproductive effects on health policy aimed on addressing it. So stigma and discrimination are attitudes, prejudice, and social behaviors that must be combated with education, with new laws or reforming existing laws on enforcement or enforcing these laws. But stigma should not be combated, fighted by distorting an epidemiological reality. I'm not saying that Mpox is a gay disease, because that's a lie, but it is a fact that Mpox, as a public health emergency of international concern, has been defined by WHO, has mainly and overwhelmingly affected gay and bisexual men outside Africa. And inside Africa, well, we know that inside Africa there is a sad tradition, there is a don't ask, don't tell. In other words, in Europe, in North America, and in Latin America, we should not stop saying the fact because of the fear of stigmatizing. So that will be my general question.
Thank you, Jorge. Felix, what are your thoughts on this? No, sorry, Gustavo.
Sure. Saludos. Thank you, Antón. I mean, contrary to what was said at the beginning, some countries might not have flat out identified MSM communities or gay men, bi men, and to some instance, even trans communities as the most affected. In New York City, that did happen. It was from the get-go, that was very clear. But then that showed us the other side of the face. Then the stigma that we experienced in New York City was very tied up to homophobia and transphobia. And there was an immediate reaction in many spaces of that's a disease of those people. Literally, those words were said. And I work in spaces where landlords even had conversations around should your clients be on the same elevators that the rest of the clients of the other tenants? And that conversation quickly devolved in huge bias and stigma and homophobia. So I do concur that it is important that we do signal who is the most impacted community, but when we talk about the most impacted, not necessarily forget about the rest of the community and put them in some context. Unfortunately, we've been hearing, sometimes we just have 3 minutes to say something. 3 minutes is not enough to convey information to a lot of people, especially in the TV, and that can foster a lot of misinformation and stigma. But I also want to address anecdotally, we also saw, unfortunately, high levels of internalized stigma. The second MPX started moving around our communities, we anecdotally heard a lot of conversations from the same community, fears between their colleagues and other members of the community, potentially about the scarring, about the effects it would have on their body, on their image. And we know that in certain circles of the community, your image might be extremely important. It should be important for all of us, but it might carry some weight. And we did see a lot of internalized stigma, at least anecdotally, among the communities, which devolved then to a degree of shunning people, shunning away from them, to a point of sometimes even this is someone's chair, no one else sit here. So I saw a lot of that coming back to New York City and to the community at a moment, which, although I was not a part of the initial HIV infection, made me understood potentially the initial responses to HIV in the community back in the 80s.
Thank you so much, Gustavo. Will, what are your thoughts?
So Antón and Lauren, thank you so much for organising today's event and inviting me to be here. Good afternoon from London. I want to build on some of the stuff that both Jorge and Gustavo have mentioned, because I think for me, what Mpox has done is it has shone a light on existing stigma that many of us are dealing with in everyday parts of our lives. I'm so happy that in the summer of last year, clinicians in my city in London organized mass Supervax Mpox events when thousands of gay and bisexual men, queer men, trans and non-binary people, people who are involved in sex work, flocked into London and were able to stand in line on a number of weekends in very, very hot summer's days, and sometimes wait for 5 or 6 or 7 hours in order to receive their first and then their second Mpox vaccination. For me, that shows resilience, resistance within our communities. It shows the brilliance of us coming together and stepping forward. But you only had to look at who was standing in line to realize that there were vast swathes of people who were eligible for Mpox vaccination who were not standing in those lines. And this, for me, encapsulates how stigma is impacting upon the health and well-being of many of our communities. And so there was a danger for some people that we knew that film cameras, film crews, media were going along to those mass Supervax events and were going along the line and taking footage, and that footage was on things like BBC News. So there was a stigma for people that they were going to be filmed. There were fears of many people that they were going to be seen either through that media footage or by people standing in line at something they perceived to be a gay event, and that particularly played out for people who are from communities where sexuality is more stigmatized than within other communities. But we also started to hear within the work that we were doing of the Love Tank of people, particularly queer migrants, who were absolutely terrified of going to those events because they were fearful that they were going to be reported to the Home Office, that they were going to be deported. Theresa May's hostile environment policies are still impacting on very many queer migrants. There were trans people who were fearful that they were going to be misgendered or not seen to be masculine enough and would be turned away from these clinics. So there's all these multi-layers of stigma that plays out in many of our communities on a day-to-day basis that were again playing out in our Mpox response, and we can't divorce that day-to-day stigma from what we're dealing with now with Mpox.
Thank you, Will. I think we have Carlos Restrepo next.
Hello, audience. This is Carlos Restrepo. I just want to continue this discussion about the stigma, but I will talk about my region. We already have 10,000 of cases, but only 3,000 confirmed and 8 fatalities. The low ratio of fatality make the stigma take 2 times, because all was related to the past government that Bolsonaro blocked everything about the medication and the vaccines, that the gay community have to be involved. But now with this government, we have a different aspect. We already received this month 4,000 doses of the vaccine. So right now the stigma, it's a little, we don't have a stigma already about the Mpox itself in Brazil. Maybe we have the combination of when a person talk about that he is HIV positive or something. It's a personal stigma. So in the past, we already have a problem, a stigma, that all the population in Brazil was very into it, and now it's a different one because it's related to the actual government. So that's it.
Thanks, Carlos. And I think, as Will said, we've seen stigma across different layers, and you all touched on different aspects related to government response, to what the dynamics that were happening and continue to happen within the community, and then how this has had an impact in, for instance, getting people access to vaccinations, as Will was saying in the UK example. So multiple layers, multiple dimensions. So thank you all for bringing this up. I'm going to transition to the next question with Ricardo, Felix, Carlos, and Gustavo. And so, as it also happened with HIV and AIDS, the community has stepped up, and some organizations have done really good work to spread accurate information about Mpox and supporting people who are recovering from Mpox. The Mpox Community Solidarity document includes examples of best educational practices and strategies that some CBOs have implemented to support people with Mpox, for example. So I'm wondering if Ricardo, Felix, Carlos, Gustavo, we can talk about some examples of good educational practices that you've seen for prevention and or best practices to support people who are recovering from Mpox. So Ricardo, we can start with you.
Thank you, Antón. And I'm glad I'm answering this question because it's very interesting for the case of Mexico, given that the community response was so strong and so comprehensive. And at the same time, the government response was probably one of the worst in the world. And we continue to see that we are one of the countries with more new cases every week now in 2023. But on the other hand, we see a community that was informed from the very beginning. And some of the things that we did here in Mexico was, in the first in the first place, to talk with HIV organizations, with LGBT organizations, and make sure that everybody knew that this issue of monkeypox and then Mpox was coming to the country and that it was going to be unavoidable and we had to act soon. So by the time that the first case was tested in Mexico, we already had some information for the different organizations working in the issues. It was a little complicated to convince them, let me be honest, because many of them were actually like our previous panelists were saying, like they didn't want to stigmatize the population, but we at some point we built a consensus and everybody was like okay with that. We actually organized one of the first protests in the world around Mpox because we knew that in the US and Europe, the governments were already purchasing the vaccines, but in Mexico and other countries in Latin America, we had no intention of doing that. So it was a very good thing to see that people mobilize both on the streets, but also on social media. And another thing that we really encourage people, and I think that that's something that came from the experience basically in the US and Europe, was people sharing their stories, sharing what happened to them on Instagram, on TikTok, on Facebook. And really like that was an effort that was completely community-based. Sometimes they didn't have like all the accurate information, but it was definitely a great way to actually reach the most vulnerable population to Mpox. So in that sense, I think that those three things that I have mentioned show how the strengths of communities that already have experience from the HIV response and from the LGBT rights movement where like came together and created like a new, not necessarily movement, but like a new issue for everyone.
Great points, Ricardo. Felix. Oh, we can't hear you. You might be muted. There you go.
Hi everybody. Hi everybody from Barcelona. Thank you for the invitation, Antón. According to recent data, from WHO, approximately 80% of people infected with Mpox are men having sex with men, and between 38 and 50% are HIV positive. So it's clear that people with monkeypox or are at risk of having monkeypox are facing often severe marginalization and discrimination, potential discrimination. This is something that we already saw at the beginning of the HIV and Hep C epidemics, and it's totally works today. It totally works today. That slogan that said that nothing about us without us. I mean, I want to highlight the importance of the fact that the community has to be leading the Mpox response, and this is something that the guide. I mean, this guide is a great example of this, because we need to fight against that misinformation, and we need to advocate to get more professionals, sensibles with competence in LGTB, working with the LGTB communities, and to advocate for more vaccines, for more tests, for more treatments. I want to highlight also the importance of that community-based organizations has in the Mpox response, as the same that we had or we are having in the HIV epidemic response. I mean, because regarding with HIV, we are promoting frequent HIV testing and other combined strategies, including PrEP. I mean, I think that it's very important the Mpox response. It's also integrated in the community-based organizations that are working in the field with the LGTB communities, because at the end, one of the main problems is that people at risk of acquiring monkeypox doesn't have the proper place to go or have the confidence to go to show the symptoms to some professionals. So it's very important that we promote new community-based organizations in places that they don't have it, or promote organizations that people trust in their professionals. And another example of good practices, and this is related, as we will see later, about the link between monkeypox and HIV. But another good practice, example is try to provide HIV treatment for everybody immediately after diagnosis, and try to retain these people in care, because it has been seen the importance of being properly immunized to get a good response to the monkeypox. No, and about another good example of how to support people recovering Mpox, I would say about the telemedicine. No, because we need that professionals are able to contact to their patients by video calls and telephone calls, because they are in a situation that they can come back to the centers. No, so telemedicine is doing a big deal.
And we just recently heard the example in Mexico. There was a regional Mpox symposium a couple of weeks ago at Clínica Condesa, the largest ambulatory HIV clinic in Latin America. And one of the CBOs that was there mentioned that they were providing emotional support to people recovering from Mpox through Zoom. And so I think, to your point, Felix, about the use of Zoom, telemedicine to support people in this outbreak. Carlos, what are your thoughts on best practices or educational resources?
Okay, in this topic, I can talk about our experience in Impulse, like a gay community support. We already use the social network to advocate and educate people, not only for Mpox. We include HIV and all these ICDT. Sorry. We already use all the social network, and we do events with dynamics in order that the people go with the mind that she have to have the self prevention, not only to give you one paper that maybe will go to the trash. We use some dynamics and some different games that educate the people and make advocacy a good practice, and this apply to the Mpox too. Okay.
Thank you, Carlos. Gustavo, what do you have to say about best resources that you've seen in New York or in other places?
Certainly. I mean, one of the first things, of course, we had to battle the lack of information in Spanish or information in a language that our communities could understand. And that's one of the best practices, just to start, translate, just put the information out there. But I want to highlight that, at least for me, and I do understand translating, creating a product does require work, but that should not be the end product, because once we put that out there, then the mental health piece is important. And we made sure that we allocated time for our employees and for our colleagues to be there and to answer questions of the clients. And even if we didn't have answers, just literally hear them, be with them. We could honestly say, I really do not know the answer about this, but let's talk. I'll just be with you on the phone. And I do understand, and it's a constant battle. I might spend 15 minutes speaking with a client, and those 15 minutes I could have reached potentially 3 more clients and set 3 different appointments. But at that moment, that one person needed that. So what I want to convey with this is that it's important that we do translation, we do put information out there, but alluding to what I said at the beginning, sometimes we, just by what we put out there, we can confuse more if we do not take the time to sit one-on-one with as many people as possible. And I also want to leverage the community support. Recovery from Mpox could take 2, 3, 4 weeks. How do you eat for 2, 3, 4 weeks if you cannot go to work, if you cannot go out to do groceries? So fortunately, as a result of what we learned through COVID in New York City, many peripheral organizations that do not necessarily work with healthcare, that do not necessarily work in the vaccination or reaching specific communities, but do work in food delivery or do work in food pantry. The first thing they did was reach out to spaces like Oasis, where I work, and other places that provided services to the community more on a medical end, and reach out and said, hey, we're here, how can we help? And that allowed us to build a list of potential options. When you are talking with us, I can also schedule a food delivery for you for the next 3 weeks, or we could help you get groceries. We've talked about this already. The HIV community has been highly impacted, helping people just get their medications. Maybe they're running out, but they are just staying in their house because they have to wait until their recovery or the lesion, they're in pain. So the community, the peer-to-peer support, I think it's a huge thing we should leverage, that we should promote, and that we should work very hard as an institutions to excel and to promote among our colleagues and among the general population.
Really good points, Gustavo. And in regards to translation, I remember that campaign that I mentioned when I was presenting the document, the Respond My study here in New York, that was led by Keleto Makofane, Nicholas Diamond, and others. The materials that the campaign produced, that the survey was translated into Spanish in the summer of last year. So, just how we make certain information, resources, messages accessible to people who speak different languages. Super important point. And so one of the themes that came up in the Gay Latino conference last year that I had the opportunity to attend was condom use. And so there was really a strong conversation about condom use as a risk reduction strategy for internal lesions. And so I'd like to get Ricardo's thoughts and Will's thoughts on these. What can you say about condom use as a risk reduction strategy for internal lesions? So I think we have, there you go, Ricardo and Will on the screen now.
Sure. Well, first of all, one of the things that we saw during the outbreak was that a lot of people were among a lot of gay men were having lesions in different parts of the body, but probably the most difficult one and painful ones were in their rectum or in the anus. So proctitis, I don't know if that's the word in English, was one of the most complicated things to treat, and therefore some scientists around the world recommended that maybe using condoms could at least prevent the lesions from appearing in that area of the body. So I think that was a good reason to actually start talking about condoms again, because as we all know, in the last few years, it's like, at least in the gay community in many countries, including Europe or the Americas, many people are using PrEP or are trusting treatment as prevention, or are using other ways to avoid contracting HIV, for example. And therefore, condoms have been left aside. And even though STIs have been increasing pretty much all over the world, like condoms seem like something that is like not fashionable anymore. So I think that Mpox gave us a reason to actually put it on the table and say like, well, we might not prevent the Mpox infection completely, but if at least you can avoid having the most painful lesions in your body, then it might be a good thing. We don't have any studies that like actually show if that was true, but at least we heard from some scientists about it. So I think it's important, like both for Mpox, for HIV, and for STIs, that we actually put condoms on the table again, because they are definitely one of the best ways for HIV and STIs prevention. And we know that in many countries, including those in Latin America, we don't have, for example, other good prevention strategies for HPV, for example, like the vaccines, or we don't have good testing for other STIs. So like in that sense, I think we need to invest more on prevention. And given that we don't have other options like we do for HIV, then I think we definitely need to bring condoms back.
Thank you, Ricardo. Will, what are your thoughts on this?
So Antón, when we set up Prepster 7 or 8 years ago, Prepster being one of the biggest programs of work that the Love Tank does, one of the big pieces of criticism that was fired at us is that we'd stopped talking about condoms. And if I was actually going to swivel my camera around so you could see the other side of the office I'm in, you would see that the office is actually stacked full of condoms and lube. And we've never stopped talking about condoms. We've never given up as PrEP activists about talking about the role that condoms can play. And I've got in my hand here, I'm not quite sure if you can see it, a little pack that we put out across the summer. We distributed thousands and thousands of these little Mpox wraps that had condoms and lube, and then Mpox information inside. And we provided those packs as a stopgap measure, because it was really the only thing we could do, is to tell people about how they could think about preventing Mpox before vaccines became available. And we did see them as a temporary stopgap measure that would help prevent some transmission. And obviously they're not going to be protective during kissing or through rimming or through oral sex, for example. We distributed those condom and lube packs in places where in places like saunas and sex on premises venues and kink venues, in those groups of gay and bisexual men who are most likely to be involved in Mpox acquisition. And those condoms were not often well received with some of those men. Some of those men were very welcoming to them, but I went around one of the leather bars and noticed that the lube was being used and the condoms were more likely to have been discarded. And in some instances, we heard feedback from those guys that if we were being seen to push condoms as a measure, then it would turn folks off. They would stop talking with us, they would stop engaging with us, just as the same way as we got feedback that if we were only talking about abstinence measures, then some guys would also turn off from engaging with us. So instead, what we wanted to do was talk about that, just as we do with HIV prevention and other STI prevention, is talk about the range of things that that guys could do at the time before vaccination became widely available in the UK and in London in particular. And that included condoms, it included looking at signs and symptoms on your own body, signs and symptoms on the bodies of people you'd had sex with. It talked about partner contact tracing, if it was safe and you were okay enough to do that if you were diagnosed with Mpox. But I think for me, the biggest issue is that we need to, providing vaccine is the most effective way that we can prevent Mpox. The most effective way, as Ricardo has just mentioned, is we can prevent HPV. And we should be advocating for the full rollout globally of these vaccinations that are way more effective than ongoing condom use.
Thank you, Will. Thank you for sharing that great experience in terms of outreach, messaging, and as you said, how we can incorporate all of these different options for risk reduction in the toolkit, in the messaging that gets to people. And ultimately, vaccines, as you say, carry a very strong importance for the prevention of Mpox. Same with HPV, as Ricardo and you both mentioned. Now, I'd like to transition into talking a little bit about the correlation that we've been seeing between HIV and Mpox. The outbreak has revealed that people living with HIV who are not in treatment are more likely to suffer severe Mpox disease, hospitalization, and in some cases, death. So I'd like to ask Ken Mayer, Antonio Gerbase, and Félix Pérez if you can talk a little bit about the correlation that we've been seeing between HIV and Mpox. And we can start with you, Ken.
Sure. No, thank you, Anton, and thanks for this great forum. So we know that Mpox and HIV are sexually transmitted, and so they're fellow passengers. But the interaction between HIV and Mpox is that people who are more immunosuppressed will have the virus replicate more readily and cause more severe disease. So people living with HIV who are virally suppressed on antiretroviral medication tend to do reasonably well with Mpox compared to people who are not living with HIV. But certainly people who are unaware of their status, people who are quite immunosuppressed can have really severe courses with Mpox. So again, as the earlier conversation pointed out, I think Mpox is an existential problem that we have to deal with as Mpox, but I also think it's a wake-up call that we have to really keep talking about sexual health. There'll always be new pathogens and new nuances, and I think, a decade ago we spent a lot of energy. Some people were very concerned about the rollout of PrEP and could that lead to disinhibition. The point is, these are all technologies. None of them are perfect. As we heard, there's still a role for condoms for harm reduction, and I think if we give people the information, the tools, they can make better choices for themselves.
Thank you so much, Ken. Antonio, what are your thoughts on this?
Thank you, Antón. Well, what it was clear during this Mpox outbreak in Europe is that vulnerability among people living with HIV and AIDS was exactly the same vulnerability regarding Mpox, very similar. With other STIs are exactly the same. As we know, we are witnessing now for the 20 years an endemic state of lymphogranuloma venereum in Europe, which is the same vulnerability. Then the first link, apart from the fact that Mpox affects more seriously people living with HIV, comes the issue of integration of prevention and care. It was already mentioned by Will, and in the beginning, an extremely interesting talk by Jorge Saavedra, in a situation that I lived a decade before Mexico in Brazil. We have to deal with all these things at the same time, regarding prevention and regarding care. In an evaluation of the European response to Mpox, which is virtually vanishing in Europe now, there are some cases. We had 0 cases last week. In an evaluation, some points are related with HIV. For instance, in the Balkans, the relation of community-based organizations in the prevention of Mpox, these community-based organizations were basically the same community organizations dealing with HIV and AIDS. 3 countries that presented the plans for the springtime now in a recent web meeting last week: Portugal, in fact, Spain, Israel. They mentioned the need to integrate prevention with HIV. And this is not only important but fundamental because we have other STIs, sometimes not as serious as HIV, but more serious than Mpox, which benefit from a combination prevention. This means that condoms are very important in what is offered in prevention, because it's going to offer prevention to gonorrhea and chlamydia. The other way it will be impossible. I think vaccination for HPV, for HIV positive or not, is extremely important, and it is already proved that it's extremely effective, even in eliminating genital warts. And this will also link with the need to vaccinate regarding Mpox. Last but not least, then the way now we need to evolve is first is strengthening links with community-based organizations, because in many countries, in a diversity of countries, Central Asia, Eastern Europe, and even Western Europe, it was the key factor to move prevention and care. This is the first thing. And the second is regarding care. Care all over the world. My experience now is Europe, was Africa in the beginning of my career, in Latin America, Asia, in each region of the world, and this is true for in each different country, and sometimes inside the country, the willingness of people to engage in prevention and care is different in different places. For instance, in Asia, when I was in WHO as a staff member in 2012, when we did guidelines for prevention and care of HIV and STI among MSM, it was clear in Asia that people wanted specialized services. In other areas of the world, like in Africa, in which talking about gays and talking about sex in general is extremely different, people wanted to be integrated in primary health care. Then we should be, our target is to link with HIV and other STIs, should be to decrease stigma, to avoid stigma and discrimination, and this passes certainly through law and law enforcement, because the rest is talk and talk. We can put pressure, but without laws and laws enforcement, it's very difficult to fight against stigma and discrimination. But we have to engage with the vulnerable people and people affected by the HIV and others to see where is more appropriate to provide care. Is it in primary health care? Is it in specialized services? We need, and for instance, in Switzerland, which is very developed but very simple at the same time, Mpox vaccination was done in close contact and in fact only through the major HIV community-based organization. People booked by phone or by email, and the vaccine was provided by the community-based organization, bought by the government. Last but not least, I'm talking a little bit too much, but let me also raise the issue that Mpox is the only STI that confers immunity for a certain time. We don't know for how long, but it is a unique example in the 30 STIs we know. It's not syphilis, you can have 20 syphilis, gonorrhea each time is worse, HPV will evolve for cancer, chlamydia will give infertility, Mpox you have one, and maybe the second. The association with behavior change in Europe in general, and this is true for Portugal, for Switzerland, maybe for France, probably for UK and Germany, Mpox went down without vaccination in a public health number. Then, of course, I have no doubt with 86 confidence interval from 81 to 95% protection, the last study in Israel, that we should recommend vaccination. The question is, imagine yourself in a Ministry of Health that you have to buy vaccines. How are you going to deal with that? how are we going to calculate the vulnerability? Switzerland bought 12,000 doses and applied 10,000 doses for a population of 9 million, 4.5 million men, put 10% for 150 MS gays. This means that there's no impact possible. You don't need modeling for that. Applying 10,000 vaccines, I think France is in the range of 20,000. Germany, that took a little bit for long. Then vaccine, we should go for it, but it's a combination. Prevention, UNAIDS a couple of years ago created this issue of combination prevention, but integration, combination, and dialogue are the key issues to deal with HIV. And the Americans now, probably Paco is going to move into that direction because Mpox is going down. It's the opportunity also to learn from Mpox emergency, to put a sense of emergency in HIV care and STI. Over. Thank you.
Thank you. Thank you, Antonio. Felix, what are your thoughts on HIV and Mpox? You're muted, Felix.
Again, hi. Sorry. First of all, we know that Mpox is disproportionately affecting people living with HIV. So people living with HIV is especially vulnerable to Mpox. That's an important fact. But we also know that most of cases of Mpox in living with HIV, and people living with HIV with high CD4 count, cell counts are very similar to those without HIV. So that's a good news. A recent paper was recently published in the Lancet, analyzing almost 400 cases of Mpox in people living with HIV with less than 350 CD4s. And it seems very clear, according to these results, that the severity of the monkeypox manifestations is especially important in people living with HIV and less than 100 CD4s. So in case that we should prioritize Mpox vaccinations in contexts where there are very limited access to vaccines, the authors conclude that we should vaccinate people living with HIV with less than 200 CD4s counseled. So that I think that's important. Regarding to, of course, the severity of the skin lesions, it's impressive in these patients with very low CD4 numbers, and the numbers of deaths is also very disproportional. No? Who reported 111 Mpox deaths, and they only have specific dates about 32, but regarding these 32 deaths, I mean, we are talking about 80% of deaths are produced in people living with HIV that are not correctly immunodepressed. No, I mean that they are immunodepressed, very importantly. So we should at least provide vaccines to this population, which is very at risk of complications. And of course, continue advocating for access to vaccines and antivirals for Mpox. This is something that we should also do. And again, promote early diagnosis of HIV, because according to these results, it's very important that we promote early diagnosis of HIV and immediate treatment to everybody, no, since the moment of the diagnosis.
Thank you, Felix. I think all of these points really sustain the fact that we have to move into the direction of full integration of Mpox prevention and care within the sexual health service delivery model. And so I would like us to think a little bit more about health systems. Another aspect that the outbreak has revealed is the importance of having medical providers with LGBTQ competency, providers who know how to conduct proper sexual history taking, providers who can talk to gay and bisexual men about sexuality, conduct proper body examinations. So I'd like to ask Ken, Jorge Saavedra, and Antonio your thoughts about the gaps that you've been seeing in terms of provider capacity during this outbreak? And perhaps we can start with you, Ken.
Yeah, well, I think we have to think of sexual health as the fifth vital sign. I mean, it's important for providers to be culturally competent to provide care for heterosexual patients as well, but particularly for sexual and gender minority patients. And there's unfortunately ample literature now that we as clinicians are part of the problem, and that we really do have to take responsibility that if we're going to provide good care for people, we have to understand their sexual behavior and be able to provide informed and non-judgmental services, and to be well informed. To be a good clinician, it involves both knowledge, to know some epidemiology, to know clinical medicine, but certainly also involves a certain art, a certain um, um, laying on of hands, which means that one has to understand how to inspire trust, because um, there's no way that a clinician is going to be able to provide good care if the patient's not going to be comfortable providing a full history that's relevant to any kind of health condition that they're facing. I mean, fortunately, there are tools available. Certainly, a lot of the normative bodies now, CDC and WHO, provide resources. At Fenway Health in Boston, we've been fortunate to have some grants from the U.S. federal government that create a center. So we have a National LGBTQIA plus Health Education Center, and there's a lot of archived materials on the site. So if you just went to keyword Fenway Health and then put health education, there are slide sets, there are videos, and there's a lot of ongoing learning. There's what's called echo learning, which is a remote distance learning for healthcare providers to help train them to provide both the knowledge base around sexual health for sexual and gender minority people, but also to be able to bring problem cases, challenging clinical issues for ample discussion. So these resources are available, and certainly the key is trying to get people who have been most resistant to availing themselves of the resources to understand that they're not going to be good providers, they're not going to be good doctors, good nurses, good anything, if they really don't understand sexual health and the sexual lives of their patients, and really be able to provide culturally competent care. That's really both a human right, and again, if people take pride in their professionalism, they're not going to be competent professionals if they don't understand these issues.
Thank you, Ken. Jorge, what are your thoughts on providers' competency? I think you're muted, Jorge.
Sorry about that. In the case of Mpox, it is clear to me that we need more healthcare providers who can openly identify themselves as gay or bisexual or LGBTQ. LGBTQ friendly sometimes is good, but sometimes is not enough. When a provider asks about the sexual practice to a gay or bisexual man, to ask about a sexual practice by a person who doesn't know or knows little about that practice, or sees it as something exotic or rare, or as a rare sexual fetish, it is clear that the provider is going to transmit that fear or insecurity when asking it to the patient. Of course, heterosexual providers can help and should be trained or educated on sexuality, as Ken was mentioning, so that they can overcome these fears to ask about sexuality to a person who clearly has an infection related to their sexual practice. Not asking comprehensive sexual histories from a person with Mpox who shows obvious signs that they acquire it through sexual practice not only limits the health advice that can be provided or given to the patient, but also limits the recording of that data. That recording is necessary for research, for future research. Can we know, I know this was discussed previously, but can we know exactly if a condom provides some protection in the case of Mpox? As it turns out, we don't have scientific evidence of that, because the clinical records of Mpox, and I was trying to do that kind of research and then found out that the clinical records, they didn't record condom use, because that was not part of the standard of a history of Mpox because it was treated more like a smallpox. Couldn't the condom have protected from injury inside the rectum, perhaps, or prevented lesions inside the head of the penis? It's going to be hard to prove it now because that information wasn't recorded in most of the cases. So I do think that this kind of training, education, or hiring gay men or openly gay men or bisexual men or LGBTQ can be part of the solution as well.
Great points, Jorge. Antonio, what are your thoughts about providers' competency? I think you're muted, Antonio.
So, sorry. Well, this has been always since the beginning of my career with sexually transmitting infection, HIV, in my interest and my heart. And thank you, Ken. Ken, I think, summarized very well the need for training. And Jorge also raised the issue of having people that understand the clients being a provider, being gay. These are extremely good points. We don't escape for training adapted to different regions of the world. We don't escape from that, and we don't escape to do this together with affected communities. However, in the moment, one point, everything is very difficult, but in the moment we move in key populations, instead of MSM or instead of LGBT, gays, bisexual, and transgender, we need to address the care in a broader area. And this one point, I don't have the solution, of course, but just putting ideas on the table for us to think how we can move more effectively forward. First issue is the competency of the provider. Second is coverage. It's like vaccines. We can have a very nice clinic with people will go. It will be very difficult to establish the coverage we need to address an issue as a public health problem. Syphilis is the best example of that. And the third point that has been always a matter of concern is relatively easy to train skills, but how do you modify attitude, which is so cultural, and this each person building their sexuality since their early childhood in different settings, and then arriving at a medical school or nursing school, and don't forget another thing, arriving in the entry door, the security person. Or I was in Italy the other day in an STI clinic, and then the guy, the clerk, providing the first information to a person, and I've been in primary health care and specialized clinics so many times, but then I was a little bit close to see, and the way the clerk treated the person that wanted testing for gonorrhea, it was so bad that the person probably won't return to the place. Then attitude, it's difficult, but we should try, and it is an important component of training.
Thank you, Antonio. And I think, as Ken was saying at the beginning, it all begins with trust. And then Jorge raised the issue of sexual histories. We don't have enough tools for providers to do this well and comprehensively. And then, as you said, in the end, it's all about patient experience. And if someone has a negative experience with a healthcare provider or with a health system, it's not likely that they will return. So all of these different issues really have to be taken into account if we want to be more effective at reaching out to people and keeping them in sexual health care. I'd like us to reflect now on vaccinations, and I know some of you have mentioned points related to this. Some places have been very good at rolling out vaccines, while some other countries like Mexico, unfortunately, haven't even approved the use of the vaccine. And so what is it that we've learned so far from the vaccination rollout efforts, and what are next steps in countries where we haven't seeing the vaccine being approved or rolled out. And if we can start with Ken, that would be great.
Yeah, I think the vaccination is incredibly important, and we know in the U.S. That although vaccination took off initially, that we don't think that everybody who needed to be vaccinated has been vaccinated, and certainly with the summer months coming and people feeling pandemic fatigue, pride's coming on board in the northern hemisphere. I think we really have to think about redoubling the community education efforts so that everybody who might benefit can get vaccinated. We also don't know how long the vaccination will have efficacy, so we're going to really need to continue to have surveillance and monitoring in place. And particularly as somebody living in the United States, I think that even with a somewhat progressive federal administration, I think they've been very short-sighted in terms of thinking about this as a global issue. And certainly we heard about the low rates of vaccination in Mexico because of the government's failures in policy there. And I think the U.S. government really has to play a role as supporting efforts internationally so that we get everybody vaccinated who can benefit, because we're in a global universe, and we're one plane ride away from the next outbreak. So I really think this is the time to really be pushing all the government bodies in our respective countries to ensure that the community avails themselves of this very potent vaccine, and that we have good surveillance to be able to track its efficacy over time.
Thank you, Ken. Gustavo, I know that you were involved in the rollout efforts of the vaccine here in New York. Can you share your thoughts on these?
Certainly. I mean, it shouldn't be news, but if it's news, we should all hear it. The rollout in New York City was haphazardless, at the least. Unfortunately, system failed. People were not able to get the vaccine even if it was available. And the best way that the city was able to respond to that was including the community, making sure that the community was an active part of the vaccination efforts. And this happened in two different tiers. At the beginning, the Department of Health reached out and said, hey, community members, hey, CBOs, could you please talk with your clients and bring them to our space? Wonderful, but that really didn't work. And you might have the resources, you might have the vaccines, but I have the trust. I have the people that speak in the language of the community. I have the people that look like the community. I have the people that serve the community in other subjects and other needs more than just a vaccine, more than just a prick. So fortunately, sometime during the outbreak, the health hospital systems in the city partnered with CBOs like Oasis and other places, and they said, hey, we know you have the trust. Let me put my resources on your place. Please open the door of your house to me, so we can come in with our resources and provide the services in your space. And we gladly said, yes, please come in. But I said, this is my home, you follow our rule. So from the beginning, we started a relationship that was in a partnership. It was not me coming into your space. I stood up and said, okay, you're coming in, but these are our hours of operations. When you come in here, please make sure that you bring people that speak in Spanish. When you're here, please make sure that all of this happen. And if you're not able to provide that, then this is not going to work. And fortunately, at that moment, the hospitals and health system of the city said, yes, let's go ahead. And we were able to create mobile pop-up clinic, vaccination clinics on site at Oasis and at up to 72 different community-based organizations, clubs, and mobile units that allowed vaccination to happen and roll out in a way that it would have never happened if we would only rely on going to a sexual health clinic in the government, or if we would only go directly to a clinician. That was not going to work. The people are getting the services in our space after hours, on the weekends, not on your usual 9 to 5, that's the hours that many people work. So it's important that if you are not, if in your country it hasn't rolled out, please make sure that you plan this before the rollout. It will help you a lot. But if you haven't, make sure. But if you already did roll out, please make sure that you bring the community in. And most importantly, when you bring in the community, respect it and treat it as a partner. Many of the people that work in community-based organizations precisely get work, and we leverage them because we have lived experiences. But everyone forgets about our lived traumas. And we should be treated as partners in the conversation, not as your help when you are coming in to get services in spaces like ours.
As we mentioned, unfortunately, in Mexico, the vaccine hasn't been approved. And so, Ricardo, I'm wondering if you have any thoughts about the situation in Mexico.
Yes. Well, as I said in my first comment of this panel, the response from the government in our country has been disastrous. And one of the many examples is the fact that not even with an emergency declaration of the Mpox pandemic by WHO, the vaccine was approved by our regulatory agency. And actually, the approval of the vaccine has been one of the main objectives of the advocacy efforts by many organizations and even by many scientists and academics around the country, because we're at some point we said, like, well, the government probably is not going to buy the vaccines, which of course we're still fighting for, but even if they don't, at least approve it and we'll find a way to bring them to the country, because we see also that there's a lot of demand. Like you just need to go to Twitter and see that every time someone talks about Mpox, people start saying, like, hey, when is the vaccine coming? Like, what happened with where can I get my vaccine? And our response is like, well, unfortunately you cannot, because we don't have it and is not even approved. So in that sense, I think that we should really take advantage of the fact that in Mexico and many countries in Latin America, the acceptance of vaccines in general is very high. Well, with COVID pandemic, there was some skepticism, and like the anti-vaxxers movement had some impact, but still, like, people really want to get all the vaccines available, and also people are starting to demand the vaccine for HPV, the vaccine for hepatitis B, and a few others. So I think that if we have the demand, we really need to make sure that we have we're offering the services that will have the highest impact in the community. So I think that like this has also showed that the community-based organizations are now being like lawyers and doctors and like psychologists, and like given that all the things that we've heard throughout the panel about the things that we've been doing for the last year or so.
Thank you, Ricardo. Sorry, I was muted. Antonio, I know you mentioned before the importance of CBOs in the vaccination rollout efforts. Again, looking at the landscape right now, places where we don't have even approval for the vaccine, and then in some other places like the US where these efforts need to be sustained. What are your thoughts for what's next?
Look, quickly some thinking. First, the best book on STI history was written in the United States, and the name is No Magic Bullet. Then this is true for STIs, this is true for HIV, this is true for the new STI, which is Mpox. Then it's about combination prevention. It's about the use of the vaccine in combination with other prevention and care issues, including condoms, because with 55% of genital lesions and anal lesions in Mpox, we are not going to have the scientific evidence at the level Jorge mentioned, but we are going to have common sense to say that we have other STI and condoms. That first, combination prevention. Second, community involvement, because of the most vulnerable groups are organized. Third, we have to link with PrEP. No doubt that vaccination is not for everybody, shouldn't be for everybody. It's targeting through community-based organization, target linking with PrEP that will benefit. And then examining in each country which is the best mix to do that. Do not forget that we need to calculate how many doses we are going to buy. It's extremely difficult, because nobody would like to be blamed to buy 5 million doses of vaccine if our vulnerability is for 500,000. Then it's going to be accused in the future of links with industry, etc., etc. We are doing about serious and ethical public health, international health. Then, in order to avoid that, instead of doing wild calculations based in methodologies which have the best intention, but it's very difficult, I think the best thing is to build from the experience of community-based organizations in a determined country, saying, okay, we are providing involved, we have 10 community-based organizations involved, each one with X people living with HIV, providing care, or some countries with sexual health. We are talking about a potential of that. And then have a look in PrEP. Because if we buy $500 million, and Mexico is a very good place to do that. I think it's most unfortunate that the government was slow, probably because of stigma and discrimination. But Mexico has a golden opportunity now, involving community-based organizations, having a look in PrEP in order to do a serious calculation, and then adding epidemiological surveillance with granularity. We need more data about vulnerability. We are saying, we know it's 98.5% men of this 35-40% HIV positive, probably gays, bisexual, and around 89-90%. But this is a subset. This is a subset. If we assume that we have 8% of gay, I'm talking about now the Western concept of gay, let's say 8%. All 8% of a male population, and we are talking about gay men, or everybody going to gay pride, everybody going engaged in multiple sexual partners? Of course not. Of course not. Heterosexuals, they have subset, cis-sexual, they have subset people related to age, cultural, adolescent, phase of life, etc. Then it is difficult. I'm not saying it is easy, but with some insights. It's not about control of sexual. This is an individual right to fortunately that it's changing in the world. It's an exercise of freedom to do with their own sexuality what we want to do, what you want to do, what the populations want to do. But if we are concerned with eliminating STI, HIV, etc., we need to learn more who is vulnerable and why. And then the question of epidemiological surveillance, it will be important. Then my last message is that, repeating, vaccine won't be the magic bullet because epidemic vanished in Europe without significant population subset coverage. This is true for France, for Germany, for Portugal, for Spain, for Israel, maybe not. First, it is vaccine is one element. Second, do not buy it. I'm giving advice, not based in randomized control trial. If I'm a minister of health, I won't buy millions of doses of vaccine. I would try to build, but having a mechanism with community-based organization, we can start with 10,000. Let's see your coverage, and then suddenly this is very fast. We need coverage to increase, but be careful not to buy too much vaccine at this time. Over.
Thank you, Antonio. We're reaching the end of the panel, and I'd just like to remind people that you can put questions on the YouTube chat. I know we've had some comments. I'd just like to bring in Jorge Saavedra and Will back to the screen because we know that transmission of Mpox during this outbreak has been happening through sexual relationships among men. Yet there is an interesting issue here. There's been a strong resistance to address the elements of sexuality that have characterized the outbreak, as we've been talking about in the last hour. So I just wonder if Jorge and Will, you can share your thoughts about this, and should Mpox be categorized as a STI moving forward?
So I think, again, it's the fear of stigma, the fear of talking about sexuality, the fear of invading the privacy of sexuality. Epidemiologists have no problem tracking measles or tuberculosis contacts. They have standard protocols and they follow them perfectly. well with the WHO guidelines, for example. But when it comes to sexually transmitted infections, this is paralyzed by fear to sexuality, to talk about sexuality. And I'm convinced that this has been the first and the main reason for not saying that Mpox is a sexually transmitted infection, officially saying that by governments, which can also be transmitted by other means. That we know that some other ways of contacting can be transmitted as well. But the primary, it was in this case sexual. The same happens with syphilis or HIV. They can be transmitted during pregnancy or by blood transfusions, but primarily they have been sexually transmitted and they have been classified that way. I heard many epidemiologists to talk about at the beginning of the Mpox outbreak outside Africa, and a lot of them, they were mentioning a party in Ibiza where many had been infected, talking about conglomeration and contact transmission. But I don't know how they imagine that gay and bisexual men in a big dance party getting infected by dancing near to each other. But the lesions appear in the anus and the genitals because they didn't disinfect the glasses or surfaces, stairs or chairs well. They thought that they were lesions inside the rectum. So it's clearly about fearing using that sexuality is happening here and everywhere and also in Paris. And I think that's why many governments did a poor job in communicating with the most affected communities. They feel that addressing sexuality issues is controversial, and to show the real lesions in genitals, as the ones you showed, Antón, in the genitals and the anus, is pornography, and that's why they are not using it. And because of that ignorance about LGBT sexuality, Q sexuality, is that the best work has been done by the communities themselves, by peers. And one of the comments in the YouTube section, Ruben Mayorga from PAHO told us that the Pan American Health Organization just subscribed a memorandum of understanding with Grindr, which is great. That's an example of what governments should be doing in order to address these issues. If they don't want to talk about sexuality and they are fear of labeling this Mpox epidemic or situation as sexually transmitted infection, and therefore they cannot develop good communication materials, they should sign or support agreements with communities and with these kinds of applications for gay men who can really address and explicitly address and achieve the intention of campaigns. So
Thank you, Jorge. Will, any thoughts on your end?
And Antón, I wouldn't say anything that Jorge hasn't already really eloquently said. And I know we're running out of time and we've got a couple of questions. So if I might just flip to one of the questions that I know has been asked about collaboration with business. And I know Grindr has been mentioned. Grindr for Equality, certainly from our perspective, have been brilliant, as have other apps like Hornet and Scruff and Recon. But we've also been doing some great work with sex on premises venues in London and in other parts of Europe. And those venues have stepped forward, have asked us for help and advice on whether they need to do enhanced cleaning, what protocols they should put in place to support their staff. If any of their staff members felt that they had Mpox, we've also worked with some of the festivals and events that have very kind of queer spaces, again across last summer, being able to help those businesses have good, supportive, equitable, thought through policies and protocols in place to ensure that staff rights are protective. And we're also not reinforcing stigma against some of those people who may go into, for example, a sex venue and a sauna and have pre-existing skin conditions, so that they're not thrown out if they have eczema or psoriasis or acne, as we were concerned about by some of the the early protocols that were being developed. So we have some really great examples of working with business, and I can only say that the businesses that I've worked in within London, club promoters, saunas, sex on premises venues, have been absolutely brilliant and have fully understood the role that they must play in partnering with community, with government, and with other NGOs.
Thank you so much, Will. So I think we can all come back for the last 5 minutes of the discussion. And Lauren, I don't know if you want to highlight some of the comments that you've been seeing in the chat. I know Jorge already mentioned the comment from Ruben Mayorga from Pajo.
Yeah, we're seeing a lot of questions about vaccines, about tactical questions about how to roll out vaccines, which I think you all spoke to. There are a lot of thanks for all the important work that you all are doing, because like one comment says, Mpox hasn't gone away, and people are worried about the complacency that is being seen across different stakeholders. So if any of you all want to expand on the question that was just answered, if you've experienced any success in collaborating with businesses during this outbreak, love to hear from you all.
Does anyone else want to add something?
I mean, I would highlight, and kind of went over it, but New York City DOH really worked very directly with a lot of clubs, and that was a huge piece of it all. Unfortunately, not all the clubs are as open or as willing to, and that could convey a lot of other things. So, for example, having people that provide the mobile unit, if there's no space inside the club, and this collaboration between businesses that do have these resources and bring them to the community, put it in our hands, put it in the hands of the people that believe and the community trust, to make sure that the work is more efficient.
Thank you, Gustavo. And I know there's another question right in the chat from Ruben. I just put it there.
Yeah. So are there any final comments regarding the use of tecovirimet for severe Mpox for those who are severely immunosuppressed due to HIV infection?
There's an active trial underway, but because of the outbreak declining, I don't know that we're going to get answers anytime soon. But I think apropos to the other points made, I would recommend that everybody who's part of this conversation today in the audience really think about where there's local activism that can be conducted in your countries, in your cities, because there's so many questions we still don't have, and it'd be great to be highly prepared and not have a new outbreak next summer. But I think it would be worse to keep making the same mistakes. And certainly the uptake of public health responses was laggard even in the best countries, and totally deficient in many parts of the world. So I think there's still an agenda for Mpox activism in the broader context of LGBT health activism that really needs to be conducted, so that we keep thinking about sexual health and don't let it go off the table, because if it's not Mpox, there may be something else next. So we have to really keep pushing our public health authorities to be thinking more expansively, to engage community, to be able to address these issues.
Well,
there's one more question related to vaccines, and it is, what is the guidelines around vaccines in terms of getting doses into communities that haven't received them, or the time frame when it comes to people who need a second round of shots?
I mean, I can add, New York City just sent a Dear Colleague letter, and they are recommending once again that the providers, at least in the city, go back to the subcutaneous vaccine instead of the intradermal. Fortunately, there's no inventory issues right now, but that was very clearly said in the letter. I think some people didn't have clarity on that, and they might be presuming that they could continue doing the intradermal, although it's valid. The city is starting to say, please go back to subcutaneous. At least that's what's happening in the city.
regarding treatment, may I? Regarding the coronavirus, I think treatment, it is more or less clear that should be reserved at present for serious evolution of Mpox. Let's not It will be very difficult because, fortunately, the most serious cases are not so frequent. It will be recommendations will be based probably not in randomized controlled trials, but in common sense and clinical experience, expert opinions. But let's not try to say that the solution from Mpox, as it is not the solution for other STI, is only treatment. For HIV, is prevention for treatment. For syphilis, yes, not for Mpox. That countries, I think, should be aware that they need treatment for serious cases, not for everything, not for every case, because most of them subside alone. Over. Thank you.
Yeah, those are all great points. Thank you all so much. Antón, I pass it back to you. I think those were all the questions we got.
Great. And so it's been a fantastic journey that started with a conversation around stigma. Then we talked about best practices, the correlation between HIV and Mpox, and then different issues related to health systems, from providers' competency to what we've been seeing with the vaccines. So I just wonder if we can go around the room and perhaps if folks want to share like one final thought on what's next in terms of the response to Mpox. Whoever wants to start, really.
Well, I can start. One thing I've been saying a lot over and over again is Mpox reminded us that we are having a very weak response to STIs, and it shows that there are many areas of opportunities for treating STIs, including Mpox.
Thank you, Ricardo. Who wants to go next?
Right. I framed this conversation less on where the outbreak is going and more, if I can play with words, where it's staying. And I think we are not really sure where it's staying, what's going to happen in the summer. So I think it's very important that we do start a few months ahead and continue normalizing, continue maintaining sex-positive conversations, continue making sure the vaccination is available where it's available and even becomes routinary as needed, while we are not clear on what the summer is going to bring and what the next opportunities are going to bring in the next few years.
Maybe jumping in a different issue, I think one of the messages is with me for the last decade is I would like to see people dealing with sexually transmitted infections, with Mpox and with HIV and AIDS, thinking more on sexuality as a whole, on sexual health, with sex as an exercise of freedom and pleasure without thinking sickness. On the other hand, and that's my problem with my colleagues with UNESCO chair on sexual health and human rights, is that people with primarily this with sexual pleasure and freedom think a little bit about there's the side effects of pleasure, which are HIV and AIDS and Mpox and STI. I think sometimes these two groups of people, they go in a separate paths, and the dialogue is very difficult. And this, last but not least, gives to the fact is that the epidemic of Mpox in Europe, at least, is really a side effect of the exercise of a freedom to exercise sex with multiple sexual partners, which is true in other parts of the history of STIs. But how to deal with this is a challenge, but the overwhelming umbrella for this is the fight against stigma and discrimination with laws and laws enforcement. Over. Thank you.
Thank you, Antonio. I think we have 4 people who still haven't shared their final thoughts. I don't know who wants to go next. Will?
Okay. I just want to say that I thought Gustavo's point about community engagement, community vaccination was spot on. Absolutely. I could not, I totally agree, and shares our experience in London. I think for me, the thing that Mpox has demonstrated once again is the resilience and the resistance of our communities. And that's something to be proud of. We've done it. We've stepped up once again.
I agree with all the comments that have been made. The only thing I would add is that as a clinical researcher, I'm incredibly frustrated about how much we still don't know and can't anticipate. So I would just suggest that everybody on this Zoom should really be thinking about how we can leverage, how we can be activists to kind of leverage public health authorities not to be complacent and then be caught off guard if we see a resurgence. And I think to really think about what are the lessons learned for public health authorities in engaging with communities so that we can have a much more prompt and effective response in the future.
Felix, please go ahead. Just think you're muted, so you.
Sorry for that. Again, my message is focused on the importance of vaccine advocacy. I mean, all MSM and transgender people with multiple sexual partners should have access to be fully vaccinated, or at least people living with HIV with a low CDC numbers. But this is the minimum. And the other important thing, in my opinion, is again the fact of try to promote community-based organizations and integrate Mpox into a fully strategy to take care of sexual health of the community. This is important.
Thank you, Felix. Carlos, do you want to go next? I think, Carlos, you're muted perhaps, or then I don't know if we're still with Carlos. But Jorge, do you have any thoughts on your end?
Yeah, I would just like to highlight this situation in Mexico that Ricardo shared with us, and that the government of Mexico has been in denial in terms of approving the use of the vaccine. And regardless that the cases are lowering, that doesn't mean that the risk is not there. I mean, it has not been eradicated. And if it were like another vaccine for a different purpose, it is there. Like cases of measles in Mexico, there are none this year. Is vaccine available? Yes, it has been approved. It has been approved for many years, and it is there. Cases of yellow fever in Mexico, 0, but the vaccine is there and has been approved. So Mpox has not been eradicated. Mexico ranks among the top ones with the most cumulative cases, and also with the new cases among the top one. And we still don't have the approval of the vaccine. So any kind of initiative coming from outside that help us to fight this institutional government homophobia or stigma and discrimination against our community will be helpful. Is in any organization that has like 100 doses to be donated to Mexico and want to highlight that will help us to fight for our causes and also to advocate better. We are trying to use a legal way to force the government to approve the vaccine. So it's not that lowering the number of new cases that means that we don't need the vaccine anymore. I think it was mentioned that vaccine is part of the more comprehensive strategy, but still needed.
Thank you, Jorge. And with that, I will just proceed to close the webinar. Thank you so much for people who are interested in taking a look at the document. Again, you can download it through the Bitly, or you can check the ACU Innovation and Consulting website on their projects, technical guidance documents. You'll find it there, both English and in Spanish. And the recording will be available on YouTube as well, so people will be able to share and continue commenting and reflecting on some of these issues. So thank you so much to everyone, and happy rest of your Thursday.
Thank
It
you,
was
everybody.
a pleasure. Bye, everybody.
Gracias.
Pleasure. Bye.